kind invitation to participate in this snack meeting. My name is Francisco Lobo from Portugal, at this moment working at the Cleveland Clinic in Abu Dhabi. And I'm going to talk about postoperative neurocognitive complications, reviewing what are these complications and how we eventually may prevent the occurrence of postoperative cognitive complications. So that's a challenge for 20 minutes. Anyway, I'll do my best to review all these concepts. So I'll try to review the PNDs, recognize the interaction between predisposing and precipitating risk factors. I'll try to shed some light into the perioperative neuroinflammatory process, and then in the end, what can we do to prevent PNDs? So classically, we may divide the cognitive complications after surgery and anesthesia in these three types: the emergence delirium that can happen in the PACU or in the after awakening, the postoperative delirium, which may happen during the first 24 to 72 hours after surgery, and then the postoperative cognitive dysfunction, which may be recognized and happen during weeks and months, even permanent after anesthesia and surgery. There's a very recent reformulation of this nomenclature published in 2019 in different journals, and I think it's more detailed. But from a practical point of view, let's keep our attention in this emergence delirium, postoperative delirium, and postoperative cognitive dysfunction. So this is an issue that is in the media among a lot of patients ask now about problems in memory and in cognition after anesthesia. And it's interesting, if we look to this paper published some years ago in Lancet, that there's a new trend in what the patients are worried about. So if you look to this survey in 1972, 30% of the patients had no fear, some have about pain. And then what's in more recent surveys, what we have is fears about brain injury and memory loss. And we have a lot of reports in the news, right? So for example, this American writer, he had a heart surgery, and he reports his own experience after the surgery. The issue is, this is not new, right? So in 1887, Savage was describing cases of insanity after anesthesia. Okay, after ether, what's the problem with that? Some years after, in the 50s, Bedford was an internist in London, and they reviewed the records of almost 1,200 patients over 60 years and who had surgeries under general anesthesia, and they found 10% of patients who had mental deterioration. And they related this cognitive decline with anesthetic agents and with intraoperative hypotension, and Bedford suggests that operations on elderly people should be confined to those who were unequivocally necessary cases. It's interesting to see that elderly people in 1954 was 50 years old, or 55. 50 years old. So it's interesting the life expectancy changed during these decades, right? So the problem is that we cannot escape from aging, and aging is associated to a natural decline in cognitive performance. This is very well related with changes in anatomy and in physiology of the central nervous system. The cerebral blood flow decreases. The anatomy in dendrites and neurons are very marked with age. So there's the aged brain is a pro-inflammatory brain. So there's changes in white matter. There's a dysfunction in the network connectivity. So the brain in aging is a much more vulnerable, and there's no mechanisms of compensation. So these old patients who have surgery, they are more sensitive to complications after surgery and anesthesia. So that's the background for these issues. Despite the detail that we may have cognitive problems, and we are going to see mainly in patients who are not old, but they are frail, they are sick, and emergence delirium, for example, is common in children, and as you know. So let's review these three general types of postoperative cognitive disorders. Delirium is a very common postoperative complication that manifests as an acute fluctuating failure of the brain to support normal arousal, normal attention, and organized thinking. There are several criteria for the diagnosis of delirium, but can be hyper and hyperactive. Despite the emergence, delirium is very, is most of the times it's a hyperactive delirium, right?
They're bringing you some right now.
Oh, wow. Wow. You set up at all?
In a minute, I'll see if they'll lift you up, okay?
The doctor sent you? Don't do it. Whoa. I've seen. Are you a model?
Nope, I'm gonna be right here with you. You eat the cracker. My name's Candace. I'm your wife.
You're my wife?
Yeah.
Holy shit.
Well, this is a very nice emergence delirium, right? So, but most of the time, what we have is a patient screaming with a terrible agitation. But this is typical, this failure to have an organized thinking and to recognize familiar situations and people. We have some data about risk factors and patient characteristics. And for example, it's common to have an association between anesthesia with volatile and emergence delirium, for example, and the previous emergence delirium is also a risk factor. And this delirium, as I said, the postoperative delirium can be hyperactive or hypoactive. And we may identify premorbid factors predisposing for postoperative delirium, advanced age, previous cognitive problems, interestingly, a low educational level, frailty, some visual and hearing impairment, depression, drug and alcohol addiction, poor nutrition, and a previous history of delirium in previous surgeries. So, and then we have factors that can precipitate delirium. And this interaction between them can be an explosion of problems, or we can act on them and trying to decrease the incidence of the delirium. That's how we may contribute to prevent the occurrence of postoperative delirium. And so this is a paper published 2 years ago by the American Society for Enhanced Recovery. And so I think that today it's easy to detect those patients who are at high risk to have delirium, right? It's interesting that during the idea that regional anesthesia, for example, was protective. Well, this is a very recent published paper, and it's a study comparing the effect of regional or with general anesthesia on occurrence of postoperative delirium in patients undergoing hip fracture surgery. And what we can see is there's no difference. So the patients with general anesthesia, volatile or TIVA, compared with patients having spinal or epidural, combined with peripheral nerve blocks, also in the general anesthesia group, there's no difference in the incidence of postoperative delirium and other problems. So it looks at it's not the technique, the anesthesia technique that matters only. There's something more behind the occurrence of the delirium. But that's an open road for further investigation. What we know today is that patients who had delirium after surgery are at high risk to have permanent cognitive problems in the future. So we have to prevent occurrence of the delirium. And even more, we have some data showing that mortality, long-term mortality, is higher in those patients who had delirium, even adjusted to other possible covariates justifying eventually a higher mortality. And so postoperative delirium should be a real concern for us. And it's now considered a surgical quality parameter. So I think that we have to be really aware of this problem, and we should avoid occurrence of postoperative delirium. Postoperative cognitive dysfunction is the decrease in or impairment of the intellectual function, presenting as impaired memory or concentration. Is not detected until days or weeks after surgery, may last during several weeks, months, even to be permanent. And there are also risk factors, precipitating factors. They are quite common, the same as a postoperative delirium. But something that we cannot also escape is to the contribution of the surgical insult. Marvin Mays and Susana Vacas, a very good friend also from Portugal, who is also a speaker in this iSnack meeting. So they have been doing a lot of research among this. They have this very interesting and I think valid model showing that the peripheral surgical insult triggers a systemic inflammatory cascade of events with changes in the blood-brain barrier, expression of strong neuroinflammation in some regions of the brain. The hippocampus, it's a very important target of this neuroinflammation. And then in the hands, this long-term potentiation disruption, changes in the glial cells and in other neuronal networks are possibly the mechanisms behind the cognitive problems, which may be potentiated by other factors and the anesthetic insult also. So how to prevent postoperative neurocognitive disorders? So I think that we have to have in our mind that we have those patients, the normal population who have with age an impairment of cognitive performance. Then we have a population that is at high risk to have a faster decline in cognition. For example, patients with sickness, with genetic background, frail patients. And then we have high-risk patients who are going to have surgery, who are going to have intraoperative surgical events, anesthetic events that can increase even more the risk to have a faster decline in their cognition. So what can we do to change this? To make different the surgical and anesthetic perioperative events. Even we can stop or even improve this. For example, pain, chronic pain, if we increase the quality of life, possibly decreasing the chronic pain, for example, after a hip arthroplasty or knee arthroplasty, we can even improve the cognitive course of these patients after surgery. So that's where we should pay attention. So education and training, pain control, avoid antipsychotics and anxiolytics drugs, and have a cognitive screening before surgery in our pre-anesthesia testing clinics with a screening delirium. There are very fast mini-cog tests, very easy to perform tests to detect high-risk patients, and some other non-pharmacological interventions are very important to prevent this. For example, cognitive rehabilitation before major cardiac surgery changes in a very significant way the course of these complications. The same for delirium. And I would say that preservation of cerebral physiology is important. Is it difficult? Yes, many parameters that should be avoided, but we are neuroanesthesiologists and we have to share our care, our knowledge to our colleagues who are not so involved with the patients having a frail brain, right? So preservation of blood pressure, it's important. Avoid hypotension during anesthesia and surgery, it's essential. And then we may have healthier drugs. And we have some data that showing that intravenous anesthesia may be protective with lower neuroinflammation, and I think that dexmedetomidine has a very important role here, decreasing the incidence of delirium. Eventually, NSAID drugs like parecoxib, decreasing the neuroinflammation, has also a role. And it's very important to measure the clinical effects of the drugs in the brain of our patients. For example, decreasing and recognizing and avoiding the burst suppression and with intraoperative EEG monitoring. Burst suppression is not normal. Electroencephalographic burst suppression is not normal and should be avoided and should be seen like a brain arrest. So we have to resuscitate this brain. And even if we see the power of alpha activity during anesthesia, we can detect patients who are at high risk to have post-operative delirium also. The way the patients awake, we can see the course of emergence. We can see and change this course, for example, with a small bolus of dexmedetomidine. If we see these 4 and 6 trajectory from very deep anesthesia to a fast awakening. Pain control is important. So we have to start a very post-operative, very good post-operative management during anesthesia, possibly using EEG and some sort of nociception balance monitoring. We have a very interesting study published a few months ago showing that guided anesthesia by SedLine and EEG and ANI, analgesia nociception index, decreases the incidence of delirium, and then oxygenation. So if we detect patients with a poor brain oxygenation before anesthesia, we can detect these patients and we can pay more attention during anesthesia. And NIRS, for example, may help us to construct the individual autoregulation curve, and we can see the limits of the autoregulations to see what blood pressure the patients may tolerate or not. And decreasing this blood pressure, we saw before that we are decreasing the risk of postoperative cognitive problems. Gathering information from EEG, brain oxygenation monitors, we improve the outcomes regarding cognition after surgery. So take-home messages: yes, cognitive disorders after surgery and anesthesia are common and are a serious burden. Preoperative optimization is essential to decrease the incidence of these neurocognitive disorders. Intraoperative anesthetic management should include TIVA and dexmedetomidine, paracoxib, brain monitoring with EEG, and non-invasive cerebral oximetry with NIRS, and normophysiology, and nociception and T-nociception balance monitoring. I think it's also very important. Data so far exists for ANI index, and postoperative pain management, promoting a familiar environment, early mobilization, early discharge are important goals to achieve in the postoperative period. And the general principles: keep homeostasis, normal volemia, normal tension, normal capnia, normoxia, normal glycemia, and normothermia. Thank you very much for your attention.